Many physicians and hospital administrators see electronic health record documentation generated by large language models as a tool that could help physicians reclaim some of the time that they currently spend on computer work. But the insertion of text generated by large language models directly into the medical record could have effects on the quality, efficiency, and humanity of healthcare. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Liam McCoy, a resident physician in neurology at the University of Alberta. Dr. McCoy has co-authored a perspective article about large language models and the EHR. Dr. McCoy, broadly, what are large language models and how do they work?
Large language models are artificial intelligence systems that have been created based on taking very large amounts of text, usually from the internet, but also from other sources, and training with initially a simple objective of predicting the next word that should take place in a document. Initially, this allowed these models to have very interesting skills in terms of knowledge generation and understanding. But what we found is, surprisingly, these models have been able to achieve performance on a wide range of tasks, including tasks in areas like medicine. Common examples of LLMs include things like GPT-4 or ChatGPT, and now things like Gemini with Google and many other companies trying to make similar systems.
And in what ways are these large language models being used in note-taking and other clinical tasks in medicine?
I would say there's roughly two buckets of approaches that are being taken for large language models in medicine at this time. The first is the application of large language models to what many see as administrative sorts of tasks, whether that is helping physicians write notes, following clinical encounters, or helping to generate documentation necessary for insurance purposes, or helping with other sorts of administrative and structural tasks. The other area is the attempts to bring large language models into what some might regard more as the core practice of medicine itself, with things like bots that are able to speak with patients and answer their medical questions, or medical LLMs that are designed to work almost like a sort of AI Dr. House, answering consultation questions and helping with complex diagnosis.
So you've probably begun to answer this question already, but in your article, you say that using text generated by large language models could lead to several problems. And you cite the original implementation of EHRs as an instructive example. What healthcare problems were caused or exacerbated by the approach that was used in originally implementing EHRs?
Yeah, so you're absolutely right. We try to draw on a historical perspective in regarding these tools and recognize that there's a sort of path dependency to technological development where we can end up making decisions that seem quite logical at the time, but have unintended and complicated downstream consequences. So, kind of working through the history of the medical record broadly, initially, medical records were what we would call a source-based medical record. I would write a narrative note explaining my interaction with the patient. The physiotherapist might write a narrative note explaining their interaction with the patient, and so on. These source-based medical records were very comprehensive and included a lot of the individual assessments of the physician, the same way that somebody telling a story might. But there were concerns at that time that they were quite unwieldy. They were quite complicated. You'd have to have the entire context of the chart in order to understand what was going on. In the mid-20th century, there was an approach called the problem-oriented medical record that was designed as a way of reshaping and standardizing the record in a very structured fashion. So instead of somebody telling the entire narrative of a patient with, say, heart failure, diabetes, and a new pneumonia, each of these would be taken out, put under their own heading, and regarded separately. So if you were interested in the pneumonia, or interested in the heart failure, or interested in the diabetes, these would each be in different segments and different sections of the chart. And the development of electronic medical records came sort of within this milieu and absorbed the broader culture of medicine at the time. There was this notion that electronic medical records and problem-oriented records broadly were the best way to organize information in sort of very clearly structured ways. While this is a noble goal, what has ended up happening is the attempts of inserting structure into electronic medical records have further divorced the content of the record from the intention and thoughts of the physician. So providers will complain about things like click fatigue, where a system might require you to individually click all of the different aspects of your physical examination, or boil a patient's complex and overlapping set of diagnoses down to 5 or 6 specific codes that can be used for appropriately billing. The critics of the problem-oriented medical record and subsequently electronic medical records based on them really highlight the ways that the use of this technology has sort of imposed an artificial structure onto medicine and has moved us away from a more holistic understanding of patients. And interacting with these systems has led to a lot of fatigue, a lot of burnout. A lot of physicians really claim to hate these systems and feel that they spend a lot of time working outside of work, that essentially they're more clerks interacting with a computer than they are people interacting with their patients.
And then when it comes to large language models, you're concerned that the generated text will reduce the overall informational quality of the patient's chart. So why might that occur, and in what ways could it be harmful?
I think one of the things we're trying to raise the alarm about is that there are a lot of uses of these technologies that seem deceptively simple and straightforward, but are actually much more dangerous than they're appreciated to be. Going back to the example I used earlier, something like the AI Dr. House answering questions for you is actually a lower risk tool in the sense that these might be treated as suggestions, that a physician is going to have some sort of discussion. An appropriate physician might regard this as a second opinion, although of course there's concerns about being biased by incorrect information there. But a lot of these so-called simple tasks are actually very deceptively dangerous. So we choose to highlight kind of a number of areas of concern here. Speaking broadly about things like chart summarization tasks or documenting a clinical encounter, the errors made by these tools might be really subtle. Language models are very good at being fluent and they're very good at answering questions, but they're not always truthful when they answer. They have something that is in the field called hallucinations, or I guess in a more medical terminology, we refer to them as confabulations, where the model produces a plausible sounding piece of text that an average person in that circumstance might have, but doesn't actually apply to that patient. An example might be the model erroneously declaring that a patient who has heart disease and also lung disease has diabetes. A lot of patients have all three, but not every patient with heart disease also has diabetes. So these subtle errors that can come in during these tasks might be difficult to detect and difficult to deal with. And so when we were thinking about the different ways that LLMs might impact charts, one is that worry that I just highlighted about confabulation and about bringing in erroneous information. But we also realize that there's a number of ways that even if the information is factual, there can still be problems that arise from the use of LLMs here. So one example is chart clutter. The easier you make generating notes, the more notes you're going to end up having in your system. Suddenly, when everybody can easily generate an LLM-driven note, you might have dozens of notes every week rather than one summary note from the team. As you get more and more information in the chart, it becomes even more unwieldy to synthesize through that information. Even if each note is factual, it's hard for me to find the focus among those notes. There's also an issue of decreased information density here. And we're concerned that this sort of leads to a loop where physicians are then going to be incentivized to use LLMs to summarize all of this complex information that they were just given in these LLM generated notes. And then alongside this, there's kind of this subtle way that results from how LLMs work, that they might oversimplify things. And this is because they're built on these large, statistically sampled amounts of text. They have this bias towards the most common or the most likely. A model is likely to answer in a way that reflects other things in its data. So, for example, it might suggest a very common treatment when in fact the patient is on a more uncommon treatment for a given disease. And we've found, and the statistical literature supports this, that when you insert more and more large language model generated text in these contexts, it actually makes it harder for future models to learn based on that information. So it's subtly less dense, it's subtly lacking breadth. Then the next model is trained on that and further loses some density, further loses some breadth. And over time, you can even end up with something that we call a model collapse, where you have attempted to make a model, but it has lost all of the breadth and nuance it had because it's went from training on high quality human generated text to training on subtly lower quality machine generated text.
So what do you see as the effect on clinical reasoning, for example?
This is another area that I think we often underestimate from a human-computer interaction sort of perspective. So note writing, as tedious and difficult as it can feel sometimes, is a very important cognitive task. You ask most trainees, residents, especially early on in their training, they'll spend a lot of time reviewing the chart and preparing a note even before they go to see the patient, because this allows them to think through and to sort of structure the information. When we are writing a note, whether it's before or after an encounter, we are making a commentary on the information that we think is important. If somebody has a broken bone in their leg, for example, you'd want to include information about the function of their foot and the mobility of their foot and so on. But you're not likely to include a lot of information about their gut health and function, for example. So we have already included some of our assessment in the act of shaping the information, the act of choosing what information goes into these notes and into these charts. In terms of what the impact of LLMs on clinical reasoning is, I think the answer is frankly that we don't know for certain. There is some evidence of something we term automation bias, where people are more likely to trust an AI system than they are the equivalent recommendation of a human being. There's evidence that people are quite susceptible to being anchored on the diagnoses that are suggested. This has mostly been tested in the radiology area. But in terms of free form text generation in charts, it's an uncharted territory that I think we need to really examine in a thoughtful and nuanced way with real world trials, not just looking at metrics of how accurate is the text. So you could have very accurate text that makes a physician not look as closely or makes a physician miss something. And I think this is one of our primary concerns, that there's a lot of justified excitement, but in this excitement, we may be missing that complex evaluation that's necessary to know how this human plus machine system really functions in the real world.
And finally, are there steps that could be taken to help ensure that the use of these large language models in note-taking and in other tasks could help clinicians to be more productive without negatively affecting care?
I think, as we say in our paper, we're certainly not Luddites or technophobes. We're very hopeful about this technology. Myself, Dr. Rodman, and Dr. Manrai all work in this field of trying to generate systems that work well and impact patients. I would say the first and foremost thing is to make sure that we evaluate these things in their real, empirical, real world context in ways that allow us to see their cascading and possibly downstream effects. I think this includes things like the interaction between the physician and the model, the interaction between physicians and patients, patients' perceptions, patients' trust. Certainly, there are myriad issues that we couldn't get into in this paper, but are well known regarding bias, where models might include the racial, gender, and other biases that are reflected elsewhere in society and subtly reproduce them. I think empirical evaluation of these things with a very close attention to these oftentimes more subtle impacts is going to be absolutely essential. And another area that we advocate for is sort of taking a pause and ensuring that we are really designing informational systems that best serve the needs of physicians, patients, and frankly, also future AI systems. We want to make sure that we have good, high quality information in the medical charts. We want to make sure that our systems are accessible. Part of the reason we bring in this historical perspective is we don't want to get caught in the same sort of path dependency that the early EHR developers found themselves in. The early EHRs, you have to click a button in order to open a sort of virtual chart that was meant to open a physical chart. There's all sorts of things that have been carried on from the status quo, where the software is often a lot more clunky than other things we're used to using. You can use an online editing software, and multiple people can write the same note at the same time, but that's not really tending to be available in things like electronic medical records at this time. And so I want to make sure that when we're going through yet another massive paradigm shift in how we approach information, we're starting from a position of what is most useful for us, what is most usable for us. I want people to hear the myriad complaints that physicians already have about electronic medical records and ensure that we are not just inserting these tools in a way that solidifies the status quo, in a way that solidifies the primacy of long written free text notes as the be all and end all of understanding our patients. I think we want to make sure that we take our opportunity in this time of tremendous change to ensure that we have systems that support the humanity of patients, that support the humanity of physicians. I think there's a ton of potential in this field, but as Thoreau said, we are the tools of our tools. And so the ways we think, the ways we practice are intimately shaped by the ways that information is presented for us. And I want to make sure that all of these perspectives are brought along the way as we go through this LLM-driven revolution.
Thank you, Dr. McCoy.